All right, let's try and break this example down. It's an ABG problem. There's a 36-year-old gentleman who has type 1 diabetes mellitus who comes to the hospital. He has fever, nausea, vomiting, abdominal pain. He has been having this for a day. His arterial blood gas shows pH of 7.26. His CO2 in artery is 20. His bicarb is 13, potassium of 4.8, sodium 140, chloride of 98, a bicarb of 12, BUN 20, creatinine 1.6, and glucose 355. What acid-base problem does he have? And the answer is elevated gap metabolic acidosis and metabolic alkalosis. The problem is, how do I arrive at that, right? So let's try. The first step is to check the pH. 7.26 is acidosis because less than 7.4. So he has acidemia, right? And then what explains that acidemia? So acidemia can explain by two things. It can either be a high CO2 or a low bicarb. If it's high CO2, it's a respiratory problem. A low bicarb is a metabolic problem. Normal bicarb is 24. His bicarb is 13 in ABG, 12 in MP. Does not matter for this particular case where you look at it, but then you'd soon notice in your critical care rotations mostly that you'd be asked to look at the BMP to determine what the bicarb is. The popular teaching is that bicarb in BMP is a measured bicarb and bicarb in ABG is a calculated bicarb. So look at the BMP, it's 12, which is lower than 24. So this is a metabolic acidosis, right? The third step, if it is a metabolic acidosis, is to find out what the compensation is. The compensation for metabolic acidosis is respiratory compensation, and for metabolic acidosis, we use Winter's formula, right? Calculate the expected PaCO2 from Winter's formula. It comes down to 26 plus minus 2. The way I calculated that is 1.5 times bicarb plus 8 plus minus 2. His bicarb is 12 in BMP, so 1.5 times 12 plus 8 plus minus 2 is 26 plus minus 2. And because his PaCO2 is 27 and his expected and measured bicarb is almost same, so that means the compensation is appropriate. What that means is that there is no respiratory problem going on. So whenever compensation is appropriate, it just means that there is absence of opposite disorder, meaning if it's a metabolic primary, then there is no respiratory. If it's a respiratory primary, then there is no metabolic. That's all compensation tells you. It does not mean that the pH would be normal. It would go towards normal if it's a good compensation, but it will not reach normal. It will never overcompensate. Step 4, after you calculate compensation, is to calculate the anion gap. And anion gap you calculate by using sodium, bicarb, and chloride. There is a video in the channel for anion gap. You're welcome to watch it if you don't understand it very well. Because your gap here is 30, which is more than 12, they have high anion gap metabolic acidosis. Since compensation was appropriate, there is no respiratory disorder, and since this is high anion gap metabolic acidosis, what can this patient have in addition to high anion gap metabolic acidosis? So the patient can have non-anion gap metabolic acidosis, and they can also have metabolic alkalosis, right? They cannot have any respiratory disorder, and the reason is because the compensation was normal. So just two of those things can still be present. What do you calculate to find out if a patient on top of high anion gap metabolic acidosis also have metabolic alkalosis or non-anion gap metabolic acidosis? The answer is delta gap, right? So you calculate delta ratio. So how do you calculate delta ratio? That's our step 5, right? Delta ratio is delta A by delta B. A change in anion gap, a change in bicarb. Anion gap here is 30, which is 18 more than normal. Normal is 12. So delta A is 18. Bicarb here is 12, which is 12 less than normal. Normal is 24. So delta B is 12. It's very conveniently delta A by delta B. It's easy to remember. And this also translates for me to delta B, B for blame. So whatever the difference, always blame the bicarb. So delta ratio here was 1.5, but for ketoacidosis, delta ratio is supposed to be 0.8 to 1.2. So there is expected delta ratio for all the clinical scenarios. This person, type 1 diabetes, fever, nausea, vomiting, abdominal pain, acidosis, obviously have diabetic ketoacidosis. For that, your expected delta ratio is 0.8 to 1.2. If it were lactic acidosis that you are worried about, your expected delta ratio would be 1 to 2, right? So their delta ratio was 1.5 as we calculated. So it is higher than what we expected. What that means is bicarb is also higher than what we expected. Wherever delta ratio is, that's where bicarb is. If it's higher, then delta B is lower, and that's why bicarb is higher. I'll explain what delta ratio is and how to think about it in next video, but then the easiest way to think about it is if delta ratio is higher, bicarb is higher than expected. If bicarb is higher than expected, then they have metabolic alkalosis. They have elevated gap metabolic acidosis, which means the differential is ketoacidosis. Given the scenario, they have metabolic alkalosis, the differential is, or they have been vomiting and probably dehydrated, so some contraction alkalosis going on, right? So those were the things to think about. Thank you.